Well, good morning, everyone. I'm going to go ahead and jump right in since we've got a pretty packed agenda today. I'm Jessie Lewis, the clinic coordinator. Welcome to Cardio-ECHO, Tackling Type 2 Diabetes series. I'll go through our usual reminders. If you could be sure to chat your name and your practice name into the chat feature so we can record attendance. And then if you need to rename yourself in the participant list, you can just hover over your name, select the More button, click Rename, and type any text into the open field there. Be mindful just to keep yourselves on mute, and feel free to ask questions or comment in the chat throughout the session at any time. And I'll go ahead and turn it right over to Dr. Dungan.
Well, good morning, everyone. I'm Kathleen Dungan, endocrinologist at OSU, and I am pleased to facilitate this session. I'd like to introduce the rest of our hub team today. Gautam Rao, would you like to say hello?
Good morning, everyone. I'm Gautam Rao. I'm the chair of Family Medicine and Community Health at Case Western and the director of the ECHO program.
And I'm pleased to also present our didactic presenters, Sadeer Al-Kindi. Could you say hello?
Hello, this is Sadeer Al-Kindi. I'm from University Hospitals in Case Western in Cleveland.
And welcome. And Jim Warner also will be helping with this didactic.
Yes, good morning. I'm Jim Warner, Associate Professor, Department of Family Medicine and Community Health, and I do weight loss work with Dr. Rao. I'm a behaviorist.
Great, thank you. And finally, I wanted to see if Mary Winfield is on the call. If so, could you say hello to the group?
Hi, everybody. I'm Mary Winfield. I'm a nurse practitioner with Signature Health in Ashtabula.
Great, thank you for presenting today. All right, next slide. So again, this is the structure of our clinics. As a reminder, we'll have a 25-minute or so didactic presentation, might go a little bit longer than that today, followed by 25 minutes of the case study. And in both of these sessions, we'll have a brief question and answer and discussion. So for those sections, you can please turn on your video and chime in with by unmuting your microphone, but you can also use the chat feature. And then we'll have a brief wrap up. Next slide. These are our disclosures. These were emailed to you a couple of days ago. Next. And without further ado, let's get started on our didactic. This is type 2 diabetes in the context of cardiovascular risk. And this will be presented by Dr. Al-Kindi and Dr. Warner. Go ahead. I believe Dr. Al-Kindi, you're first.
Yeah, thank you very much. I'm just going to do a quick, brief introduction about myself. I'm an assistant professor of medicine at Case Western and a cardiologist at University Hospitals. I co-direct this Vascular Metabolic Center of Excellence called Cinema at University Hospitals, which is focused on metabolic and cardiovascular and metabolic risk prevention. Thank you for joining us today. Next slide, please. So the learning objectives, we're going to describe briefly the epidemiology of diabetes and cardiovascular disease and how they interact. We also will describe how diabetes and associated risk factors can increase the risk of cardiovascular disease and how we can tackle both at the same time. We're going to identify therapies that are approved to treat diabetes and also lower cardiovascular disease risk with a special emphasis on GLP-1 agonists and SGLT2 inhibitors. And we're going to talk about an evidence-based approach to smoking by Dr. Werner. So, this is not a foreign concept to a lot of people here. Basically, cardiovascular disease and diabetes coexist. And here we are showing the cardiovascular or coronary heart disease mortality, cardiovascular mortality, and total mortality that increases as the cardiometabolic risk increases. So if you have metabolic syndrome or diabetes, or if you have cardiovascular disease, and if you have both, you can see coronary heart disease mortality increases by 6-fold. Same thing applies for cardiovascular mortality and total mortality. So it's a big issue that we have to tackle. These patients are the highest risk, and it's very, very important that we actually tackle both diabetes and cardiovascular disease at the same time and lower the risk. Next slide, please. So this is a meta-analysis, one of the premier meta-analyses published in Lancet that shows what is the impact of diabetes on coronary heart disease, stroke, and other vascular death. And you can see across the board, diabetes doubles the risk of all cardiovascular events. So it's not a small increase in 10-20%. No, it's actually a double risk of cardiovascular disease risk. Next slide, please. And it is also not foreign concept for a lot of you that if you have diabetes and you get a complication, myocardial infarction, stroke, ESRD, or heart failure, the risk of death in these situations is very, very high. So you can see here, there is 200,000 hospitalizations due to MI and diabetes in the United States, and out of those, about 75,000 deaths, 75,000 hospitalizations lead to death. So across the board, it's about a quarter to a half of the hospitalizations lead to death in patients with diabetes. So very drastic kind of increase in cardiovascular risk. Next slide, please. The problem is that we've been doing a lot of, we've been doing a good job for a lot of years to actually decrease the cardiovascular risk profile in patients with diabetes by lifestyle changes, additional therapies, for decades. But, in the recent years, about 2010 or so, there has been an increase in cardiovascular risk profile in patients, especially younger patients with diabetes. So on the left side, you can see that there is a resurgence of acute myocardial infarction, stroke, diabetes, ESRD, amputations in younger folks, 18 to 44. Same thing, less dramatic, but same thing is happening in the middle age, 45 to 64. And in the people who are aged more than 65, you can see a flattening of the curve. So all that work that has been done for decades has been kind of flattening and plateauing in the previous years. This is probably because of an increase in obesity rates and an increase in other non-traditional risk factors that we have not been doing a great job at. Next slide, please. So this is a nice study that was published in 2019, which looked at 120 centers across the world. And the question that they asked was simple: how many patients who have type 2 diabetes are on optimal medical therapy? And you can see here, we do a great job with statins. 88% of the patients are on lipid lowering, on statin or any other lipid lowering therapies. We do a great job with antiplatelet or anticoagulants. That's also about 90%. We do a less great of a job in glucose lowering therapy. So if you look at SGLT2 inhibitors, only 9% of the patients are on it. GLP-1 receptor agonist is 8%. And keep in mind, this is a lot of the big centers, big academic centers. I anticipate that if you expand this globally, this will be much lower percentage. So only 7% at the end of the day, only 7% of the patients are on optimal medical therapy for both lipid lowering cardiovascular medications and glucose lowering medications. Next slide, please. So how does diabetes lead to cardiovascular disease? That question has been asked and tried. People try to answer it multiple different ways, but I think at the end of the day, it's a kind of a multi pathway that is involved. We know that a lot of things that contribute to the incidence of diabetes are also contributing to the cardiovascular disease. So when you take a patient who has diabetes, type 2 diabetes, they are more likely to have been on poor diet, physical inactivity, obesity, smoking, but also have a lot of non-traditional risk factors, socioeconomic status, environmental exposures, others. that lead to diabetes, but they themselves can also lead to cardiovascular disease. But then we have a concomitant comorbidities in patients with diabetes, which are more common in these patients. So dyslipidemias, platelet activation, metabolic dysfunction, environmental pollutants. And also that leads to endothelial dysfunction, arterial stiffness, inflammation, and oxidative stress. So as you can see, it's a very complex kind of mechanistic approach, and it's and a lot of these pathways are actually bidirectional. So diabetes can lead to inflammation, which can worsen diabetes, which can lead to cardiovascular disease. So this is an oversimplification of the pathophysiology. Next slide, please. What has been shown, which is a very interesting way of thinking about diabetes, is if you normalize risk factors, the traditional risk factors, smoking, dyslipidemia, blood pressure, and glycemia, then these patients don't carry an additional risk. So this is a very nice population-based study from Europe that was published in New England Journal of Medicine a couple of years ago, 3 years ago now, that looked into, in the first row, you can see the control as a reference, which are patients who don't have cardiovascular, who don't have diabetes. And they're looking at, in each panel, they're looking at a separate, different cardiovascular outcomes. So mortality in general, you have myocardial infarction, stroke, and heart failure. And as you go down, control, and then you have diabetics, but don't have risk factors. So controlled, ideal kind of cardiovascular profile. And as you go down, it goes up to 5 risk factors. And they're also stratified by age. So I want to draw your attention to this segment here. For example, when you compare the controls and the no risk factors, the diabetics who have no risk factors, they're actually exactly the same. There's no increased incremental risk. This suggests to us that a lot of the risk that's that double risk or triple risk of cardiovascular disease actually can be controlled by controlling the risk factors that are associated with cardiovascular disease in this patient population. Next, please. So how can we lower cardiovascular risk in type 2 diabetics? Next slide. A lot of the there's a lot of evidence-based approaches to lowering risk, but it all focuses on the treatment of concomitant comorbidities. So as this is no different than treating any patient who has no diabetes. So physical activity, nutrition, healthy nutrition, which is important, weight management, cigarette smoking, glycemic control, blood pressure, as we talked about. And all of these have been endorsed by either the American Diabetes Association, and you can see there is actually a very good level of evidence between A and B for the most part, and also by the American Heart Association for some of it. So if you control the cholesterol, blood pressure, glycemia, smoking, and so on and so forth, the risk can be minimized. It can go back to normal, or it can be minimized, somewhat significantly, and we can improve outcomes for these patients. Next slide, please. So this is a very nice kind of a semi-meta-analytic approach to looking at how can we reduce risk of cardiovascular events by using several therapies. So aspirin has been shown in multiple studies to reduce the risk of cardiovascular events by about 10% in patients with type 2 diabetes. Statins about 20%, reducing blood pressure less than 140 about 11%. Nutrition, interestingly, nutrition here has been shown to be even more effective than aspirin, statin, and lowering blood pressure separately. Lifestyle changes can also reduce it, but then if you do both lifestyle and medical therapy, you can see a reduction of 50%. And that, if you remember the slide that shows that the increased risk in diabetes is about twice. So by halving the risk, you're going back to normal risk. And that has been also shown in retrospective studies. Next slide, please. So I'm not going to spend a lot of time here on treatment of blood pressure in patients with diabetes, but I want to focus on a couple of things here. If the blood pressure is way too high, you start 2 agents. This is based on the diabetes practice guidelines by the ADA in 2021. If the blood pressure is moderately elevated, then you start with 1 agent. And it's very simple. If they have an indication for ACE or ARB, start with that. Albuminuria, coronary disease, I would add to that heart failure. And if they don't have it, you have the ability to start with a calcium channel blocker or a diuretic, and then reassess and then add other therapies down the road. Next slide, please. When we talk about statins or cholesterol management in these patients, multiple meta-analyses have been performed to look into the efficacy and the effectiveness of statin in patients who have type 2 diabetes. And the bottom line is that it's actually no different from any patient who does not have diabetes. So the management of dyslipidemia should not matter whether you have diabetes or no. We assume that patients who have type 2 diabetes, they have elevated risk. So we are at lower threshold to start them on statin medications. But in general, the efficacy and the effectiveness of both statin in both type 2 diabetes patients and non-diabetic patients is exactly the same as shown here in front of you in this meta-analysis. Next slide, please. So there's been a lot of confusion. Should we prescribe aspirin? Should we not prescribe aspirin in patients who have diabetes? And it's also very simple. If you have an indication for aspirin other than diabetes, includes coronary disease, secondary prevention, then yes, by all means, prescribe a low-dose aspirin, typically between 75 and 162. What we use is a baby aspirin of 81 milligram. If you have no indication from a secondary prevention, if you're talking about primary prevention, there is a lot of mixed data, and trials have shown that there is a decrease in cardiovascular events, but also a concomitant increase in bleeding. And whenever you have that signal, like we do all the time in cardiovascular outcome trials, it's very difficult to understand what is the overall benefit when you have bleeding and you have lowering of MI. Would the patient rather have a bleeding, or would the patient rather have MI? And it becomes a patient-centered kind of discussion. So with the American Diabetes Association, all of these are from the most recent guidelines. They suggest that we have a discussion with the patient. So we can consider it, we can have a discussion with the patient and describe the data and have a shared decision-making in that approach. Next slide, please. So we have a lot of new kids on the block here in treatment of diabetes. Next slide, please. So I'm going to be focusing on 5 different classes as the time allows. I'm going to talk about SGLT2 inhibitors, GLP-1 agonists. I'm going to talk about Icosapently Ethyl, which is a Vascepa, which is one of the newer therapies for treatment of hypertriglyceridemia. I'm going to talk about direct oral anticoagulants and a P2Y12 antiplatelet therapy for prevention of cardiovascular events, and specifically in patients who have type 2 diabetes. Next slide, please. So the buzz is all around SGLT2 inhibitors and GLP-1 agonists. And how do these work? The bottom line is actually we don't know a lot about how does it reduce cardiovascular events. We have theories, we have surrogate outcomes that we've looked into, but we actually don't fully understand how these two therapies lead to a dramatic reduction in cardiovascular morbidity and mortality. The hypothesized kind of mechanisms are, we know that SGLT2s on the left side, SGLT2 inhibitors, can lead to hemodynamic effects through increase in sodium and uric acid and glucose excretion through the kidneys. And these can reduce the preload, reduce the afterload. There have been studies that looked into epicardial fat and hepatic fat as a surrogate measure of visceral fat, and these also go down with SGLT2 inhibitors. And obviously, because of the diuretic effect, you get a lot of impact on heart failure and volume retention. But all of that does not really explain fully why the reduction in the incidence of heart failure and the outcomes of heart failure, especially in patients who have no diabetes. As you know, there are data now to suggest that SGLT2 inhibitors can also work in patients who don't have diabetes. So how do these work? We have no idea yet. GLP-1 agonists, we have a little bit of a better idea, but it's still in the works. We know that GLP-1 agonists can decrease gastric motility. They can increase insulin and decrease glucagon excretion. and that way they can reduce postprandial glucose. And by reducing gastric motility and signaling to the brain, they increase the satiety and can cause a little bit of nausea, especially early on. So all of these can lead to anti-atherogenic effects, and that way they can reduce major adverse cardiovascular events, nephropathy, and both of them can actually lead to significant weight loss. Next slide, please. So this is a comparison. It's a nice table that compares the overall mechanisms and effects of these two therapies. So we know that both GLP-1 agonists and SGLT2 inhibitors and their combination can reduce body weight, but GLP-1 agonists also can reduce appetite. So the mechanism of SGLT2 inhibitor reduction in weight is also not clear yet. SGLT2 inhibitors act mainly on heart failure events, while GLP-1 agonists can impact ischemic cardiovascular events. So myocardial infarction, stroke, they have a better signal of reduction. GLP-1 agonist, we know it increases insulin secretion and decreases glucagon secretion, but SGLT2 inhibitors actually lead to the opposite because they reduce glycemia, they reduce the glucose concentration in the blood. And in the same class, you get a reduction in hepatic glucose output in the GLP-1 receptor agonist, while you get an increase in hepatic glucose output by SGLT2 inhibitors as a compensatory mechanism for the glucose urea. As you all know, SGLT2 inhibitors leads to diuresis, natriuresis, increased in glucose excretion in the urine, and leads to renal protection through unknown clear mechanisms. Next slide, please. So this is a busy slide, but this tells us how we can really start therapies. How do we start therapies in patients who have diabetes? What therapies do we choose? How do we prioritize those? This is from the most recent guidelines on diabetes therapies by the American Diabetes Association. And the bottom line, this is all nice and clear in the diabetes guidelines, but the bottom line is we actually don't fully know, because the trials that included patients in the GLP-1 agonist outcome trials and the SGLT2 outcome trials were very similar. These are patients who are either had cardiovascular disease defined as a myocardial infarction, CAD, heart failure, or they are at risk for cardiovascular disease. And the inclusion criteria for trials that enrolled patients in GLP-1 agonist and SGLT2 inhibitors are exactly the same. Now, what the guidelines are driven by, they're driven by reduction in events. So what they suggest is that if you are at high risk for a heart failure, a much higher risk for heart failure than myocardial infarction, for example, then you may want to prioritize SGLT2 inhibitors, compared with if you're at high risk for atherosclerotic events like MI and stroke, then you may want to prioritize GLP-1 agonists. So that's where, on the left side, that's where they discuss if ASCVD predominates, then you talk about mainly GLP-1 agonists, and then you can add on SGLT2 inhibitors. While if the heart failure or CKD predominates, then you can start with SGLT2 inhibitors first, and then only if they're not controlled, then you can start adding GLP-1 agonists. So it gives you, this is what I'm talking about, the trials that enroll patients, they have both options of GLP-1 agonists and SGLT2 inhibitors if they're SCVD, but because of the clear reduction in events from heart failure standpoint, then we can talk about SGLT2 inhibitors, prioritizing that. And then afterwards, all bets are off. You can start really almost anything afterwards. You can start insulin, you can start DPP-4, you can start TZDs and others in patients who have not achieved glycemic control. Now, bear in mind that these medications, they cause modest decrease in A1C. So what has been shown is about 0.5 to 0.8% reduction in A1C with both GLP-1 agonists and SGLT2 inhibitors. So if you have a patient who has very high A1C that you don't expect them to improve, then you may have to start two medications at the same time, or even add basal insulin in these patients. Next slide, please. And this is, I'm not going to spend a lot of time on this, but this another slide that they have in the guidelines that tell you how to initiate insulin and additional therapy in patients who have not achieved glycemic control, or if they have high glycemia at baseline. So you can start with initial insulin and add on other therapies additionally. I'm not going to spend time on this. It's probably covered in other talks. Next slide, please. So why is this important for our primary care physicians and other specialties to actually chime in? Because we have severe shortage of endocrinologists in the United States. And this map shows you that only, there's one endocrinologist for almost 30,000 adults in the United States, which is a big deal for access. So if we leave these therapies only to endocrinologists, if we leave GLP-1 agonists and SGLT2 and call it medication, these medications should be only prescribed by endocrinologists, we are losing on a lot of efforts and a lot of opportunities to actually reduce cardiovascular morbidities and mortality in these patients. Next slide, please. So this is a very summarized version of how it's a practical approach to prescribing SGLT2 inhibitors. So we start when we want to switch either from non-metformin oral therapies to SGLT2 inhibitors, or we can add on individual SGLT2 to previously treated patients. So there are multiple SGLT2 inhibitors in the market right now. Canagliflozin, DAPA, and AMPA are the most commonly prescribed. These are the starting doses. You can see these here, and you can actually prescribe them in addition to metformin. There's no specific contraindication, but if your patient is non-adherent due to polypharmacy, then you may want to restrict it to either SGLT2 alone or metformin alone. You monitor them a little bit early on. I typically do a 1-week kidney function test afterwards, just to make sure that there's no significant reduction in GFR. But even when there is significant reduction, it can most of the time it can safely be continued with close monitoring. And then I prescribe. Whenever I prescribe, I counsel my patients about genital and perineal hygiene, orthostatic hypotension. If they are on diuretics, I also reduce diuretic dosing because SGLT2s can lead to reduction. And if they had, watch for DKA symptoms and avoid excessive alcohol. And then we monitor them for blood pressure and body weights and so on and so forth afterward. Next slide, please. I'm going to leave this slide. You're probably going to have the slides, but this is what the potential adverse events that I counsel my patients on. Typically, as we talked about, drug-drug interaction, DKA hypoglycemia, which is rare, but genital infections is what I usually focus on. Volume depletion and renal injury can be also monitored by getting a kidney function test afterwards. And lower limb amputation has been, this is something that is controversial, but typically if the patient has wounds like, CLI or critical limb ischemia or active wounds from vascular wounds, I probably avoid SGLT2 inhibitors. Next slide. So just a couple of slides here. I know we're almost close to the finish line here, but I'm going to talk about a couple additional therapies to lower cardiovascular disease risk because you may come across those. Next slide, please. So Vascepa, which is Icosapently Ethyl, has been shown to reduce cardiovascular events in patients who have moderate triglyceridemia, so 135 to 500, who are on statin and controlled LDL as an additive therapy. And this is endorsed by the ADA guidelines as a Class A indication. And you can see here the curve, which included about 40% diabetics in this trial, reduced trial, that shows a reduction of 25% in cardiovascular events in patients who meet these criteria. Next slide, please. Ticagrelor also, there's a THEMIS trial, which included patients who have type 2 diabetes, which randomized them to ticagrelor. Bear in mind, this is not the same dose that we use for coronary disease and stenting. This is a 60 milligram twice daily, in addition to lower dose aspirin compared with placebo versus aspirin. And you can see here there's about 20% reduction in the cardiovascular disease risk combo of death, MI, and stroke over a median of about 3 years or so. But as expected, it doubled the risk of bleeding. So this is the same story as aspirin. This is something to consider down the road. Next. And the last thing I want to talk about is low-dose rivaroxaban. A lot of our patients have polyvascular disease. They have carotid disease. They have coronary disease. They have peripheral disease. And this is the COMPASS trial, which compared low-dose rivaroxaban, 2.5 milligram twice daily, in addition to aspirin, and showed a significant reduction of about 30%, 25% reduction in cardiovascular outcomes in patients who have polyvascular disease. Now, this trial was not specific in diabetes, but a lot of the patients, about 40% of the patients, had diabetes in this trial. So this is something that can be also considered. It's endorsed by the AHA guidelines. Next slide. All right, in transition, Dr. Werner.
Okay, thank you, Dr. Al-Kindi. That was a fascinating presentation. So in follow-up to Dr. Al-Kindi's presentation, that showed the dramatic effects of lifestyle changes in decreasing cardiovascular risk for patients with diabetes, I'd like to talk about smoking cessation and clinical methods for doing that. Next slide. So there's good evidence to show that health-related events such as a diabetes diagnosis or increasing disease severity or hospitalization can increase patients' interest in smoking cessation, trigger attempts to quit smoking, and improve rates of smoking cessation as well. But we know that fewer than 30% of patients use evidence-based methods to quit smoking. Next slide. So the U.S. Preventive Services Task Force has provided a grade A recommendation for smoking cessation in the clinic. And this is to ask all adults about tobacco use, advise them to stop, and provide behavioral interventions and medications as well. And there's high certainty that the net benefit of doing this is substantial. Okay, next slide. So interestingly too, the evidence is strongest for physician and nurse advice. So rates of 8 to 13% of cessation rates following physician and nurse conversations with patients about smoking cessation. Telephone quit lines are also effective, as are tailored self-help materials. And this doesn't have to take a lot of time. So brief in-person counseling of less than 10 minutes or even less than 3 minutes is shown to increase cessation rates. So it may only take a minute or two to make a real difference in helping that patient quit smoking. Next slide. So I'd like to provide, a brief evidence-based approach that you can use in the clinic for helping patients quit smoking. And so you may be familiar with the SBIRT model, which is used for substance use, but it's also used in tobacco, which is a substance and has shown to be quite effective. Next slide. So what we're going to do is combine here the opening the door technique that was developed by Dr. Gautam Rao and colleagues. It's pretty widely used as a way to begin conversations with patients about lifestyle changes. And then we're going to add some elements of SBIRT and even a little bit of motivational interviewing. So this is kind of patterned after what I presented 2 weeks ago with a little bit of emphasis more on the prevention side. Okay, so step one is screening. Just simply ask about tobacco use. The second step is a brief intervention in SBIRT, and this is to express concern, medicalize the concern. So link the smoking to the patient's diabetes or patient's worsening severity of diabetes symptoms, whatever it may be. And then to ask if the patient is concerned about this as well, and to then ask if it would be okay to discuss this for a few minutes today. That's step 5, the collaboration step. And then the last step here is to assess importance, to find out what kind of a priority, what priority level does the patient place on doing this at this time? And that'll give you a good idea of how to work with the patient, what stage of change they're in. Next slide. So the referral component of the expert is, we have some great resources that I want to talk about. So you can refer the patient to the Ohio Tobacco Quit line or other resources that I'll go into. And these counseling services will work with patients who are just thinking about quitting, considering quitting, as well as those who are ready to make a quit attempt. So you can refer them to these really excellent counselors who use motivational interviewing and other techniques with patients who, if they're just simply, contemplating quitting. Next slide. So if they're not ready to consider quitting or make a quit attempt, again, you can try to refer them to the quit line or other resources, but you can provide printed information about smoking cessation risks. And then most importantly, I think, ask for permission to resume this discussion at a future visit. And then during subsequent visits, you can use brief motivational interviewing techniques similar to the ones that we just looked at to increase motivation and self-efficacy. Next slide. We're going to skip this slide. And so the Ohio Tobacco Quit line is something that probably most of you are familiar with. And they provide coaching over the telephone at no cost. These are no-cost services. Emails, text, chat, web-based materials, tracking your quit on their website. And these are all provided in English, Spanish, and they have translation services as well for their counseling. They provide NRT for up to 8 weeks for those who are working with a coach. So the patient needs to be in counseling with a coach, essentially, working with a coach over the phone on a regular basis. It's usually about 5 times that the coach and the patient talk, but it can be more if the patient needs more time. And they provide 2 weeks of NRT at a time, shipped to the patient's home. So next slide. A similar program is provided by the American Lung Association. They have helpline counselors, apps for quitting. They have group clinics. None are active at the present time. But through June 30th, 2021, Ohio residents can access their Freedom from Smoking Plus program, which is essentially their suite of counseling plus other materials. This can be provided to patients at no cost. And then they also provide up to 8 weeks or so of nicotine replacement therapy, very similar to the tobacco quit line. So this is another resource that you can use if you want an alternate source to use, or you're unable to, for whatever reason, use the Ohio Tobacco Quit line. Next slide. Smokefree.gov is sponsored by the National Cancer Institute. I think the strength of this, they provide counseling over the phone, but I think their real strength is in texting, smartphone apps, and social media. So younger patients may be more drawn to get smoking cessation help using their smartphones, and smokefree.gov has done this particularly well. They've got tailored texting and apps and social media for women, teens, veterans, Spanish-speaking, patients over 60, as well as a general approach to this for everyone else. So it's terrific. Next slide. For facilitating referrals, you may be aware that electronic health records can be set up so that you can electronically refer patients to the Ohio Tobacco Quit line, and they provide technical guidance for integrating the electronic health record if your institution is interested in that. As far as optimizing the workflow in doing this, you don't have to do it yourself as a clinician. You can have your care team members, your medical assistants, implement the referral process, which can be done electronically on the website. It can be done on paper and faxed in. So these are referrals, and they will then contact the patient. The Ohio Tobacco Quit line will then contact the patient, reach out, and take that proactive step to initiate that smoking cessation counseling. Next slide. Okay. There are many other resources for quitting smoking, which is really great to see. Tobaccofree.org provides really good point of care materials if you need something in the clinic. And There's another resource that's different, Nicotine Anonymous, uses a 12-step program approach. I checked and they have 5 in-person meetings in the Cleveland area, and they have 56 Zoom support groups available that for anyone to participate in. So this has been an effective approach for helping patients quit smoking. And then if you need guidance in for clinic level and system level cessation programs, Million Hearts provides this in guidance and tools for doing that. Next slide. Okay, so in recapping, use the opening the door technique plus SBIRT and MI to help patients quit smoking. You can refer them to these resources. And for patients who aren't ready to do anything quite yet, request permission to resume the discussion at a future visit. Next slide. Okay, that's it. Thank you.
Well, thank you so much, Dr. Werner and Dr. Al-Kindi. That was just a lot of information that's so important and useful, I think, to everyone's practice. I'll open it up for maybe 1 or 2 questions, and then we'll move on to the case.
Hi, Kathleen. Thanks to Jim and Sadeer for excellent presentations overall. I had a question for Sadeer, actually. And one of your early slides pointed out that 19% of people with diabetes are on fish oil. I've pretty much stopped prescribing fish oil. There were a number of meta-analyses that show it didn't have any benefit. The AHA statement about it was rather vague. There was another Cochrane review that said, hey, we're not sure. And when you do use the prescription version, Lovaza, it's very expensive. It's not covered. So all these people are buying stuff from GNC and other places that I think is questionable in terms of its content. So just want to know what your thoughts are about even bothering with this at all at this point.
Yeah, no, that's an excellent question. I think the best evidence base currently that we have for fish oil and related things that we prescribe is actually Vascepa. So EPA is a little bit of a more stable formulation. We give it in high dose, so we give 2 grams BID. Patients get 4 grams, and that has been shown in a couple of trials, in the Reduce It trial, and then there's another Evaporate trial which looked into progression of atherosclerotic plaque by CT. And in both of these trials, Vascepa has shown a significant reduction. So whenever if the patient is motivated enough to take supplements, fish oil supplements, I always try to switch them to an evidence-based one, which is Vascepa in this case. If the patient, and a lot of my patients don't want to get off medications for whatever reason, I'm okay with continuing it. I don't think there's a lot of signal of harm for Lovaza or others in general. It may not be helpful, but if the patient, I try to counsel them that there's really the evidence is weak at best, if at all.
Okay, so we have one in the chat from Pam Murphy. Did the data show that fish oil have an effect to decrease stroke in African Americans as a subset?
I don't know off the top of my head. I am very wary of the subsets in general. These big trials, they're designed barely to answer the primary question, let alone subsets. African American enrollment in these trials is not, super high. So I'm not sure. I don't know if this has been looked into specifically in stroke. Now, I have to say that with the Vascepa, the EPA formulation, there has been a signal of harm, which has been consistent across studies, and that increases the risk of atrial fibrillation. So this is something I counsel my patients on. It's a very small risk. These patients are not at extreme risk of atrial fibrillation, but there has been a signal of concern in multiple trials.
Great, thank you. Well, since we are short on time, I would like to move on to our case. This is really an interesting case, and it just kind of underlines, I think, a fairly common scenario, just the unpredictability sometimes of managing people with diabetes and oftentimes the U500, and sometimes the smallest thing in particular We see this all the time in people who are hospitalized. They come in on these huge doses of insulin, whether it's U500 or else otherwise. And then even if they're not made NPO, their insulin requirements are often dramatically reduced, suggesting that either there's maybe some question of if they're actually taking it at home, or there might be just vast differences in what they're eating. And so it's not always the case that just because someone's sick and hospitalized that suddenly their glucoses go up and they need more insulin. In fact, I think more often it's the opposite. So I do wonder if some of that is the case here. Is she using other medications?
So yeah, she does have several psych meds. She's on bupropion, she's on Lamictal, she's on quetiapine, all small enough doses that they shouldn't be spiking her sugars very highly. And I have her on, she has Carafate as needed when she gets GI issues. She's on the levothyroxine and she's on simvastatin.
Okay, so no other diabetes medicines?
No.
Okay.
I did try to restart the metformin once I got her back onto the Lantus, hoping that would kind of, help utilize that insulin. And unfortunately, because of her diverticulitis, she couldn't tolerate it. So right now I'm at the standstill at the Lantus 18.
Okay.
I do find we've had several patients like this where very drastic changes in their glucose levels. Especially, what I found is a lot of these patients have kidney dysfunction, and what are the pharmacokinetics of insulin with changes in kidney function, especially when the GFR is this low, is really may play a role. And what I found, at least anecdotally, is prescription of medications like SGLT2 inhibitors, which by the way is indicated for this patient because of their GFR, and this is probably the last time her GFR is about 32. It's probably the last time we can start her on it, because once the GFR starts dropping below that, it becomes a quote-unquote contraindication. So I do think that this would be an opportunity now, with insurance and coverage. It will be back and forth, but I have to say that a lot of the pharma companies, they have assistance programs for both commercial and federal programs, federal insured patients. They have a lot of what we call foundation and voluntary services. They have a lot of they are trying to help patients get on these therapies. So I mean, in this patient, my suggestion is to start a low dose of one of the SGLT2 inhibitors, if at all possible. This would do two things. One, preserve her kidney function and reduce her cardiovascular risk in general. And this risk reduction of kidney disease is drastic. We're talking about halving the risk of going on dialysis, halving the risk of worsening kidney dysfunction. So it's not minute. We need to treat 2 patients to prevent 1 dialysis. But also we are talking about reduction in insulin needs potentially, and also stabilization of glycemia over time.
Now, do you think there'll be a concern with her GI issues if I start one?
Not particularly. I typically for GLP-1s, you get a little bit of slow gastric motility, so it becomes an issue for patients who have gastroparesis. But for SGLT2s, typically there's no concern with diverticulitis or such. I have to say that it does increase your risk of DKA, so that's another consideration. But the benefit, in my opinion, for this specific patient outweighs the risk.
Thank you.
And I think you're definitely on the right track, getting her off the U500 at 100 units a day. Even when she wasn't hypoglycemic, it doesn't make a whole lot of sense.
It made me nervous when I had to take over her care, because that was nothing that I would ever want to do in a family practice. But I kind of, like I said, I was stuck with no other option, and she had been stable on that with endocrinology. So I felt comfortable at least carrying on what they had been doing.
Can I just ask a question? If you start her on long acting and say a GLP-1, would you wait to start the SGLT2? Because it sounds like her sugars are going higher now, right? That you started her on the Lantus. And so one of the things I've seen is when you start the SGLT2 and their sugars are above 200 or above 180, they have a lot of urine incontinence and issues around. I've actually had somebody that went for volume depletion, and I just wonder if starting it a little bit lower. I know Kathleen, you've mentioned that and I don't know if that's just been experiential or if you have some suggestions around when you would start that.
Yeah, I think it depends on how hyperglycemic they are. In her case, I don't know that I would be quite as worried, because with an eGFR of 32, I'm not sure that you'll see that dramatic of polyuria, polydipsia. And you certainly won't see the same level of glucose lowering that you would in somebody who has a normal eGFR. And in fact, if I actually didn't see what the actual eGFR is, but if it is 30, oh, there it is.
Yep.
I don't know that you're going to see much glucose lowering at all, but you definitely preserve the cardiorenal benefits. That's fairly well established.
I appreciate the feedback. It's going to be very helpful.
Any other thoughts? I mean, I guess I also think that a GLP-1 could still be possible with really good counseling and making sure that you're monitoring that they're not getting, dehydrated or something like that. Diverticulitis alone wouldn't make me say, okay, no, you can't use a GLP-1. DPP-4 inhibitors, might be on a, kind of on a second string if, the goal is to reduce insulin requirements, but just keeping in mind that she's had diabetes for 20 years. So I'm always a little bit hesitant but, as the renal failure progresses, I mean, that is pretty common. I mean, not maybe at eGFR 30s, but, when you start getting into CKD 4-5, yeah, we definitely see, those reductions in insulin. Other thoughts? Well, did we answer any of your questions, Mary?
Actually, you gave me a lot of good information and a good feedback, so I'll know where to go with her next, I think. If not, I'll be emailing some of you for more feedback.
Yeah, I mean, it's a shame that she's gotten tossed around a bit from the specialists. I'm not sure what to say there. There might be opportunities to revisit that if they have.
Yeah, we've tried with a couple of them because I have a pretty good rapport with a few of them, but I'm not sure she's as willing to go back as well. Yeah. So.
Okay.
Thank you.
All right, so we are just about out of time. Again, if you have additional questions or comments, if you wouldn't mind just shooting an email to Jessie, and we can maybe handle some of these offline. We covered so much information today, and I really kind of appreciate everyone's attention and engagement. So until next week, Jessie, I'll pass this over to you for our closing comments.
Sure. So just a reminder that we record these sessions. If you need to watch any of the videos from the current clinic, you can go to our website, cardio.org. For this current cohort, you will need to register for an account. And once you sign up, you should receive an email with a link to activate that account. But if anyone needs help troubleshooting that, again, please just feel free to contact us. And then the other thing is that you should have your post-clinic survey for today in your inbox already. And as usual, that'll close tomorrow at 5. So I know it's 9 o'clock. Thanks again to everybody, and we'll see you next week.
Thank you.
Thanks, everyone.